Good afternoon to all. Today we have to infection control and the prevention. As you know already, the neonatal infection or sepsis is the second most common cause of the mortality in in the world. So today we are just focusing on the neonatal how to decrease the NICU and neonatal sepsis as a whole, because as a low-income country in India, if we will take precautions or will start the preventive steps to prevent the neonatal sepsis, it will be more helpful rather to treat the babies. So the journey starts from entry of the organism into NICU to the baby, and then to prevent these infections and to build the immunity in the babies. So, newborn care is usually a vital sector to be looked to reduce neonatal mortality and morbidities. As we know, always the prevention is better than the cure. And this approach of to decrease the neonatal mortality and sepsis is a multidisciplinary. It includes neonatologists, nursing staffs, community. So effective infection controls, as I told, it starts from the journey that entry of organism or microorganism from the NICU to the baby. So as we know, the microbes or these bugs enters the NICU via visitors and healthcare workers, and this is spread to neonates via contaminated equipments in hands of the healthcare workers. Once this organism get colonized in the babies, this organism enters through either umbilical cord or breach in the skin. That was done during either IVSS, parental fluids, enteral fluids, or feeding, intubation, suctioning, or any line. So, why these neonates are more susceptible? Because as we know, they have low immunity in view of prematurity, low birth weight, they are immunocompromised, they have ineffective and inadequate level of the antibodies, and they have comorbidities just like congenital conditions. Apart from that, they also have susceptibility in view of the care related in the NICU, that is prolonged intensive care, presence of invasive medical devices, parental nutrition, antimicrobial therapy, which may lead to multi-drug resistance organism, overcrowding or understaffing, the ward layout, that is, if it is not adequately fit with this water sink, bed spacing of the units, use of invasive fetal scalp electrodes, probes, and cannula, contact with the colonized infective family members, visitors, healthcare workers, proximity of the colonized neonates, and increased length of the stay. So burden of healthcare infection in the Southeast Asia is overall is 9%, with incidence is 20 per 1,000 ICU stay. That leads to excess length of stay that may extend from 5 to 21 days. The type of infection what we are discussing is CLABSI, that is central and associated bloodstream infections. That was incidence of 4.7 to 1,000 catheter days. VAP, that is ventilation associated pneumonias, that is account for 14.7 in 1,000 ventilation days. Then UTI, that is related, that was 8.9 to 1,000, and surgical site infection. So this rate of healthcare associated infection in the newborn are 20 times higher in the resource limited countries due to the inadequate environmental hygiene and low adherence to the infection control and the prevention. So what are the steps? So as a whole, we can divide this into 8 steps. So that comes from the prevention of entry of microorganism into the NICU, prevent the proliferation of the microorganism, preventing the infection spread from the proliferation site to the baby or from one infected baby to the other, prevent entry of microorganism into the neonates. Then, for the control, breast milk or breastfeeding or correct preparation of the formula feeding, kangaroo mother care with early discharge, decrease stability of the baby to the infection and infection control the protocols. So coming the first step, that mainly account for the prevention of entry of microorganism into the NICU. So that comes with the clean immediate environment, a standard of the NICU design, and other one. So coming to the clean immediate environment. So the immediate environment for the babies are organism present in the labor room, gestation room, or maternal vessel flora that can be colonized in the newborn skin. So it can be prevented by 6 C's. So that is C's are clean perineum, clean delivery surface, clean cord, clean cutting instruments for the cord, clean cord care, ensuring nothing in clean, and all the equipments should be clean and regularly autoclaved. Now coming to that second one in the prevention of entry of microorganism into the NICU, that is standardization of the NICU design. So for that, the location of NICU that should be designated area with a controlled access. So the access to the NICU should be not to the all. Each bed for the NICU should have a space of minimum 120 square feet floor area. With the minimal 4 feet space should be in between the beds. All NICUs should have one isolation room for the airborne infection. In that, they have hand-free hand washing stations, areas for gowning and storage of the clean materials, ventilation with the negative pressure with the exhaust, and minimum of 6 air exchange per hour in the normal NICU with the 12 air exchange for isolation room. The air temperature should be kept at 22 to 26 degrees Celsius. The relative humidity should be kept on 30 to 60 degree percentage. So this leads to a void of condensation on the wall and the window surface. Whenever if the RH or relative humidity is more than 60%, it promotes the growth of the microorganism. Apart from that, there should be hand washing stations. So every neonat's bed should be within 20 feet from the hand-free sink. The washing sink should be large enough to control the splashing, and there should be pictorial hand washing instruction should be there. The wall material should be non-absorbent to prevent the growth of the molds. There should be some space for the shower and the shower, and that all the taps should be either elbow or foot operated. But for the hand hygiene, the CDC recommend hand washing before and after contact with every patient or every neonate for 20 seconds and 40 to 60 seconds before entering the NICU. The all steps should be followed as we have to remove all the accessories, turn on the water, wet hands should be done, apply the antimicrobial soap, rubbing palms to palm, then dorsum of the palm, rubbing fingers interlocked, back of the finger, rubbing thumbs rotationally, rubbing wrist and then forearm, turn off the water, wipe hands and discard papers. And each action should require minimum of 5 seconds. So this is the pictorial presentation of hand washing that should be done for 40 to 60 seconds. In one, you can see you have to do the weighting of the hands with the hand operated or elbow operated tap. After that, we have to take the soap that this would be 2 to 3 ml. Then we have to rub hands with the first palm to palm, then palm to dorsum, then fingers, the finger interlocking, then the thumb, then the pulp of the finger. Then we have to do we have to just rinse hands with the water, and then we have to dry through the either with the single use towel. and this use towel to turn off the that faucet if it is handheld, and then your hands are now safe to touch the baby. Now, this apart from that hand hygiene and hand washing, we have to follow that hand hygiene, that is hand washing and hand cleaning uh, of 5 moments, that is before touching any babies, before clean and aseptic procedure, after body fluids exposure risk, after touching the baby, and after touching the baby's surrounding. So this before touching the baby usually protects the baby from the harmful germs carried on the healthcare worker's hand. This clean so this before clean and aseptic procedure, why it should be done? Because it to protect the babies from the harmful germs, including the baby's own, from their entering his or her body. So after body exposure, so this should be done to protect yourself or healthcare workers and the surrounding environment from spreading harmful germs. And the fourth, that is before touching the baby, that is to protect yourself and the surrounding environment from spreading harmful germs. And before touching, after touching the environment or baby's surrounding, that is to protect yourself and surrounding environment from the harmful germs. So one can use also the alcohol-based hand rub. In the same, they used to take 2 to 3 ml, and they used to follow all the 6 steps what we have discussed before. If hands are not visibly soiled or contaminated, proven to be more effective than a standard hand washing used in between the patient examination in the NICU, but not useful after touching the infected patients or if your hands are soiled. In those conditions, you have to do the proper hand washing. Uh, Now the policies for the visitors. So since we know that microbes enters through the person, so there should be restricted entry. That is, the mother should be allowed at all the times, whereas all the other parents maybe once a day with proper hand hygiene and hand washing. Infected person, if they have either respiratory or GIT infection, and also the children's should not be allowed in the NICU. Infected and outborn babies managed in the isolation room, and NICU should be and must be a cell phone free zone. Now this is the presentation of hand rubbing. It is same. We have to take 20 to 30 seconds to have hand rub. So we have to take in a palmful of product, that is 2 to 3 ml, then palm to palm, then palm to back, fingers to finger, interlocking, then thumbs, then your pulp of the fingers. Then you can touch the baby. Now, the other preventive steps to prevent the entry of microorganisms into the NICU is gowning. So whether gowning should be done or not. So when they have seen, although there is no reduction of the infection, but main focus we should have on adequate hand washing. Now coming to the jewelries and the fingernail policies. So no one should wear or should have artificial fingernails whenever they have direct contact with the babies, and the natural nails should be kept short as 0.5 centimeter or 1/4 inch long. So this is a study in that they've seen the use of gowning to reduce the nosocomial infection and mortality in the NICU. Based on the Singapore experience, in that they have seen that when they have randomized the babies to the gowning with the plastic apron without gowning, they have seen that uh, there's no significant difference in the incidence of nosocomial infection and mortality in the neonates, whereas the cost of gown used during the no routine gowning period was around $2,012 compared to $3,700 during the routine gowning. So in that, they have concluded that rather to focus on adequate hand washing than having the gown. Next, the second step is preventing proliferation of microbes in the NICU. So for that, the main thing is the housekeeping staffs. So housekeeping staffs routines helpful in preventing and curtailing the spread of infection. Always avoid the wet areas inside the NICU. Because the dry and clean unlikely to harbor the microorganism. So how we can do that? So there should be a daily and weekly routine. In the daily routine, all the equipments as incubator, warmer, syringe pump, infusion pump, phototherapy unit, mattresses, pulse oximetry, multiparameter diameter, hoods, ventilator, CPAP and telephone should be cleaned with using moist wrap after dry dusting if the baby is not inside that crib or incubator or warmer. Uh, the suction bottle, modified chamber, water in the bubble CPAP should be changed with the distilled water. The ventilator filter should be cleaned daily and dust off. Bag and mask should be immersed in 2% Cydex for 6 to 8 hours and after dismantling and cleaning with the running water. Incubator and warmer should be cleaned with bacilloid if not occupied by the infants. The laryngoscope, mask, measuring tape, temperature, and SpO2 probe, and torches should be cleaned with the wipe with the spirits. Walls, floor, and wash basin should be cleaned with the phenyl, Lysol, and 2% bacilloid in each shift. Dustbin, bucket waste should be emptied in each list. Each shift. Other things, a weekly routine, that is ventilator and CPAP machine, that the circuit should be changed weekly. The procedure sets should be autoclaved after every use. A window of air conditioner should the surface and the filter with the soap and the water. Refrigerators should be shorter and clean. Separate fridge door for the milk and the lab samples. Weighing a scale, stethoscope, BP cuffs, laryngoscope should be clean and wiped with the spirit after every use. And the fitting utensils should be cleaned weekly. This is the disinfectant and the germicidal and their use and direction to use. So what we are using in the NICU, the bacillus spray. This spray is coming with the 2% that was used for the cleaning of wall of nursery, incubator and the warmer when not in use, and surface of the weighing machine. So we have to just put off the air conditioner at the time of spray. Other one is Sidex, that is 2% glutathione that was used to clean for the face mask and the ambubex and the reservoir. So before immersing into Sidex, all the face mask and the ambu bag should be cleaned thoroughly with the soap and water. And for sterilization, it should be kept for 4 to 6 hours. For disinfection, it should be kept for 15 to 20 minutes. This Cydex, once prepared, solution is active for 14 days. Other things, what we are using is Spirit, that is for skin preparation, cleaning, laryngoscope blades, tape, measuring, and stethoscope, but do not use to clean incubator and the warmer. Soap and water for the oxygen hood, feeding utensils, swabs containers, injection tray, face mask, and the bucket. After washing in soap and water, uh, uh, the the feeding utensils should be boiled for 20 minutes. Other povidone iodine usually we are not using for the preterm babies for skin preparation. We are using mainly chlorhexidine 2% solution for the skin preparations. For the housekeeping, floors would be wet mopped with the phenyl once in each shift. No dry wiping. Do not use 2% glutathione for that. Walls will be cleaned with 2% bacilloid, one in each shift. Fans should be wiped with the wet cleaned cloth once a week. Window AC should be cleaned once a week with the surface and the filter. Refrigerator defrost and clean with the soap and water once a week. Bucket should be cleaned with soap and water daily in the morning shift. And the sink should be cleaned with the detergent and the powder soap daily in the morning shift or as required. Now coming to the waste disposal, we all are using the 4 types of drums. One is black drum, yellow drum, blue drum, and white drum. That white drum is for that sharp objects. For the black drum, the any leftover foods, vegetables, waste papers, packing, empty bags should be done, and it should be disposed in the municipal council committee machinery. Yellow dumps should be disposed by incarceration. In that, we have to keep the infected done plastic or human secretions, blood and body fluids. The blue drums, in that we have to keep the infected plastic waste, just like IV sets, ET tubing, catheters, Eurobags, and it should be autoclaved and disposed by the setting. Now coming to the third step, that is preventing the infection and spread from the proliferation sites from one baby to another baby. In that, the most important is nurse to patient ratio. So if the baby has multi-drug resistant organism, the nurse to baby ratio should be 1:2. Yeah, and if the it can be kept as 1:2 if the baby is susceptible or baby having similar organism. 1:3 for adequate antibiotic cover. Uh, the all NICUs should have laminar flow system for making of drugs, fluids, and TPL preparation. Always try to decrease the local complication and the sepsis. Uh, Always use the disposables. So all babies should have their individual kits of stethoscope, measuring tape, thermometer, torch in a sterile container. Separate syringe for each medicine for each babies. Fresh section catheter for ED tube and one for oral section. Separate gloves, antibiotic vials, disposable antibiotic circuits. Do not keep formites as file, pen, X-ray on the baby cot. Flushing of catheter stock solution, that is heparinase, should not be used. Epidemics of Tribacter chloroquine with use of multi-dose antibacterial vial was noticed, so always use the single-dose antibiotic vials. Now coming to the prevention of entry of organisms into the neonates. So that comes with the cord care and skin care. So for the cord care, the cord infection prevention by the clean cord care and reducing the harmful cord application. So WHO recommends the cord should be dry and the use of soap and water solution only to clean if soiled. For the skin care, the skin injury prevented by applying less adhesive tapes, using teardown between the skin and the adhesives. So always take precautions during adhesive removal. Always make it wet with the distilled water. Use skin-friendly Durapol instead of Dynaplast and Macro. Other things that is precautions during procedure to prevent the entry of microorganism into the neonates. So for that, aseptic precautions taken during all procedures. Hand scrub prior to each procedure. Skin cleaned with the spirit, betadine and spirit. Disposable gloves should be worn. After IV cannulation, insertion fixation with the transparent tape. Cannulation site monitored daily for thermoconjunctivitis. Catheter, if inserted in emergency, removed once the patient condition got stabilized. So always follow the aseptic non-touch technique, that is ANTT. So for that, you have to always wash hands effectively. Never contaminate the key parts. Touch non-key parts with the confidence. With gloves, take appropriate infective precautions. For that, we have to go for the 6 steps. So first one is a risk assessment. So select a standard for the normal IV cannulation and surgical ANTT for that central lines. According to the technical difficulties of achieving the sepsis, manage the environment, avoid or remove the contaminated risk, decontaminate and products with the hand cleaning, use aseptic fields, use of non-touch techniques, that is, key part must only come into the contact with the key sites. Prevent cross-infection. So, these aseptic non-touch techniques have some important definition, just like aseptic technique. So, aseptic techniques means methods during the invasive procedure to prevent transfer of organisms from the healthcare practitioner or procedure equipments or immediate environment to the patients. So non-touch technique, so integral component is achieving by not touching the key parts and the key sites. So if key parts and key sites are required to be touched, always wear the sterile gloves after doing hand washing. Aseptic non-touch technique, so it includes both aseptic techniques and non-touch techniques. So that is asepsis means free from the pathogenic organism. So, so the key parts, so the aseptic field is where the designated aseptic working areas. So key parts are the critical parts of the procedural equipments that come in the contact with the patients. It is key sites for other procedure. Example, syringe tips, needle, both tips and the herb, needle-free SS device, or top of the medicine vials. So that is tip of the needle, neck of the ampoules, halves of the needles, and tip of the syringe. Now key sites, the point where the patient skin is breached, example, just like wounds, the insertion sites of the peripheral venous catheter or central venous catheter. So this photo showing key sites where the peripheral venous catheter is getting inserted. So, ANTT for the peripheral cannula insertion, 2% should be present during the procedure. Hand hygiene should be done before the procedure. Hand hygiene for the assistants, hand wash or hand gel. The trolley should be cleaned where equipment kept. Assistant open the equipment appropriately. Appropriate gloves used for the person during the procedure. A sterile field for the procedure. Cleaning of the site of the procedure with the alcohol, betadine alcohol, 30 seconds. So each for 10 seconds. Betadine of the protection of the key parts all the time, and hand hygiene after procedure. So this is the true presentation of the ANTT during securing peripheral cannulation. So first doing the hand washing, then hand drying. After that, securing that line, uh, wearing the gloves, protect the key sites and the key parts. So they have different for the standard ANTT and surgical ANTT. The surgical ANTT mainly done for the significant invasive procedure, just like insertion of the central venous catheter. There was somewhat more technical complex procedure, but the main theme of protecting the key parts and the key sites is same for both of the surgical or standard aseptic non-test technique. So this is the study in that they have seen that whether these test techniques improve the sepsis rate or not. In that they have seen that in that they have done the QI to improve that compliance with the ANTT. In that they're seeing that after after 2 to 3 PDSA cycle of ANTT, with a modest decrease of healthcare-associated infection rates were seen in a short period of 6 months of observation and implementation of this QI studies. It was done in the PGI. So next one is prevention of entry of microorganisms into the neonates. So the precautions taken during the central venous catheter or PICC line, that is umbilical catheter handling of catheter. So for that, there's a training of education of the healthcare workers, that is hand hygiene, wear the gloves, sterile gauze, sterile transparent simple dressing to cover catheter sites. Monitor catheter sites visibly on palpation. Replace catheter sites dressing if dressing is damp, loosens, or soiled. Remove catheter if no longer used or there's a complication of clavity or thrombosis. Change tube or bottles every 24 hours. This is CDC guideline for the prevention of entry of microorganisms for that USC, UVC, and PICC lines. So they tell that always remove UVC, USC, and PICC line as soon as possible, and when no longer needed due to the concern of increased risk of clavity with each day of increasing delta. So consider removal of USC within 7 days of dwell time, although the conditional recommendation is there. Also remove the UVC within 7 days of dwell time. When to remove or replace peripheral catheter, that the PICC line remains an unresolved issues. There is no recommendation. But in one study, they have found that increasing in catheters related sepsis with PICC line catheter in place for more than 9 days compared to less than 9 days. So this clavity, that is associated with blood infection, usually spread either from the skin organism, that is endogenous skin flora, contaminated from the catheter herb. That from there the endogenous skin flora goes inside and contaminate infusate, that is extensive fluid, medication, and intrinsic manufacturer. So what is the clavity bundle that we can use? So it has 3 bundles: insertion bundle, maintenance bundle, and the hub care bundle. So in the insertion bundle, establish a central line kit or cart to select all the items necessary for the procedure, perform hand hygiene, uh, disinfect skin with appropriate antiseptic, that is 2% fluoride and 20% alcohols. Before catheter insertion, minimize the number of SS port. Keep connecting port with the UVC or USC away from the diaper areas. Use either a sterile transparent simple dressing or a sterile gauze to cover the insertion sites. Prefer upper limb veins over the lower limb veins. Ensure catheter tip position. No blood stain around the insertion site. Now coming to the maintenance bundle. Perform hand hygiene with the hospital alcohol-based products. Evaluate the catheter insertion site daily for the sign of infection. And dressing integrity. If dressing is damp, soiled, or loosened, change dressing aseptically. Develop and use the standard intravenous tubing setup and changing. Maintains aseptic technique when changing the intravenous tube, that is, scrub the hub before changing the tubing. Daily review of the catheter necessity with prompt removal whenever no longer essential. Now, hub care handle bundle. So clean hands with soap and water. Put on the gloves. Establish a sterile field under SS port. Place syringe on the edge of the sterile field. Scrub SS port with the chlorhexidine for 10 seconds and allow it to dry. Pick up the syringe, keeping the tip sterile. Attach syringe to the hub, keeping connection sterile, and administer flush solution, keeping connection sterile. So now the other steps. So two precautions during intubation and suction. So in those cases, always wear face mask, scrub hands, wear gowns and gloves. The tube stay in the pack until the points of use. Do not touch tracheal tube or ET tube. Wear sterile gloves for the suctioning. First tracheal suctioning, then mouth. Discard suction catheter after single use and take help of seater and nurses for installing saline. So this is the web preventive strategy. In that we have preventive strategy. So for bacterial colonization of oropharynx and stomach, because as we already know, this web usually happens from the colonization of the pharynx and the stomach. From there, the macroaspiration of contaminated secretions happens in the AT2, and that leads to web. So to prevent bacterial colonization, there should be limit antibiotic exposure to prevent the antibiotic resistance. Routine mouth care with the colostrum mouth paint in the newborn babies. Good hand hygiene. Wear gloves when working with the secretions. Educate healthcare workers caring for ventilator patients, and oral tracheal intubation should be preferred over the nasopharyngeal intubation. Now the preventive strategies to decrease the macro aspiration. Use non-invasive ventilation as soon as possible. So always and daily see for the chance of extubation. Reduce length of the ventilation. Prevent unintentional extubation. Avoid reintubation. Do suctioning oropharynx when tracheal tube is adjusted. Change circuits only when necessary. Drain condensation away from the patient frequently. Disinfect respiratory equipment when after use, and elevate ahead of the bed. Not so much significant, but we can do an inline closed suctioning. So we can divide this web bundle into the hand hygiene, tracheal tube care, humidification, respiratory equipment care, position of the baby, stress ulcer prophylaxis, oral hygienes, internal feed, shortest duration of the intubation and ventilation, and post-intubation. So next one is breast milk or breastfeeding and correct practice for the formula feeding. So support breastfeeding always to promote its benefit to the infants. Increase use of colostrum, that is atopic feeds with the EVM and non-nutritive suctioning. Mother entry in the NICU and pumping the blood to ensure adequate milk at any time. For formula feeding, water temperature should be 20 degrees Celsius at time of reconstitution, and decrease holding and feeding time to reduce the risk of contamination. If prepared in the advance, refrigerate to or below 50 degrees Celsius, but no more than 24 hours. Rewarming done immediately before the feeding, and feed should not be left warming for more than 15 minutes. So this early maternal breastfeeding that we know that with the breast milk, it 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 leads to maturity of the GIT, brain, immune system, eye, lungs, and for the preterm babies, breast milk is associated with the development as well as grown up. So every drops count for the preterm babies of the mother's milk. So this is a checklist for preparation of the formula feeding. In that, hand washing should be done before cleaning and sterilization of the feeding utensils. Dedicated sink should be used for the cleaning of feeding utensils. Water used. So for the cleaning, we have to do the cleaning with the soap and water. Sterilization. In sterilization, the water used within 30 minutes of boiling so that it remains at a temperature of at least 100 degrees Celsius. Labeling should be done. Temperature of the formula feed tested on inside the wrist before giving to the babies, and leftover feed thrown out. Next coming for the infection control is kangaroo mother care and early discharge. So KIMS, so with a significant reduction in the severe infection, sepsis, also for the LONS, pneumococcal infection, and discharge at 40 weeks of gestation. So what Cochrane review said that that KMC leads to decreased mortality by 23% and severe infection by 50%. Other than that, decreases susceptibility to the infection by early breastfeeding, use of colostrum, neonatal feeding. So on mother's milk on colostrum lower the incidence and severity of nosocomial infection and late onset sepsis. Trophic feeding improved milk tolerance, greater postnatal growth, reduce systemic sepsis, and shortens the hospital stay. The use of immunomodulator, although there is no role of IVIG or GM-CSF for prevention of sepsis, but the role of probiotic is promising. So other things like antifungal. So fluconazole prophylaxis is recommended in the ELBW babies that impairs the adherence of candida to endothelial and epithelial surfaces and decreases the biofilm formation. It also enhances the killing of candida sepsis. So in 9 of 10 RCTs, it's shown that the fluconazole prophylaxis leads to significant reduction in the invasive candidiasis. But there is a concern about the development of resistance to the fluconazole. So it should be indicated in the ELBW babies in the units where baseline incidence of fungal infection is 5 to 10%. Now, use of probiotics preterm with the immature gut development may benefit from early probiotic exposures because that improves intestinal barrier integrity and modulates the immune system development. So probiotics such as Bifidobacterium species, Lactobacillus, either as a single or combined may be used. A systemic review by Deshpande et al. In that, they have seen that with the probiotic, it leads to reduced risk of NEC, LONS, and all-cause mortality in the preterm babies. Now, the infection control protocols. In that, we also include the role of management. So, establish multidisciplinary infection control committee who can use appropriate resources and methods to monitor and prevent infection, ensuring education and training. The physician, microbiologist, nursing manager, resident, and housekeeping staffs play their role in infection surveillance and prevention of infection outbreaks. So this infection control committee should have goal to review yearly program of activities for surveillance and prevention. They should also do epidemiological surveillance, appropriate staff training in support control and safety, and provide inputs from the investigations of the epidemics. They also control the antibiotic use and resistance. So all the hospital must have antibiotic policy, depends upon the local conditions. Politic antibiotics should not be started in birth asphyxia, jaundice, CS delivery, or exchange transfusion. Blood culture should be obtained before starting antibiotic. And if culture comes sterile within 40 to 72 hours of incubation, safe to stop the antibiotic. Always restrict the use of empirical broad-spectrum antibiotics. CRP should never be used as a guide for antibiotic therapy. Shorten duration of antibiotic whenever possible. Antibiotic stewardship, that is a multi-system team approach that limiting the appropriate use of antibiotic while choosing selection, dose preparation, and route should always be used in NICU. Treat infection, not colonization or contamination. So my take-home message is neutral sepsis difficult to treat but easier to prevent. So need multidisciplinary team. Surveillance and auditing is the key to prevention. Promote culture of sepsis practices, that is hand hygiene, housekeeping, care bundles. Always promote the KIMS and breastfeeding. Implement antibiotic stewardship program. Thank you. Thanks for listening. We'll post any queries so that we can take opportunity to just answer that questions in next sessions. Thank you.